Bismillahirrahmanirrahim. In this video, I am going to discuss atrioventricular reentrant tachycardia. It's also called AVRT. In this kind of tachycardia, there is an accessory pathway as one portion of the circuit and the AV node as the other portion. AVRT may be orthodromic or antidromic. The orthodromic pathway is shown on the left side of this figure in blue color, and the antidromic pathway is shown in the right side of this figure in red color. And we can appreciate, if we look at the orthodromic pathway, it usually has a narrow complex that uses the AV node as the antegrade limb and the accessory pathway as the retrograde limb of the circuit. Antegrade means that the flow of the current is in the forward direction, and the retrograde means it's in the reverse direction. And similarly, if we look at the antidromic AVRT as shown in the red color on the right side of the figure, it has a wide complex that is opposite to that of the orthodromic, and the accessory pathway serves as the antegrade limb and the AV node as the retrograde limb of the circuit. However, AVRT is most often of the orthodromic type, that is, the AV node behaves as the antegrade limb and the accessory pathway behaves as the retrograde limb. Now let us discuss this ECG. It's an ECG of a 13 years old boy who presented with repeated episodes of palpitations, and actually this is a case of AVRT which was proven afterwards with EP studies. So let's discuss this ECG for now. Actually it becomes at times it becomes so difficult to differentiate between AVRT and AVNRT just looking at the 12-lead ECG. However, we will try our best to elicit our findings and prove that this is AVRT and not AVNRT. So first let us calculate the QRS rate or the heart rate, that is almost 290 beats per minute, and the axis is towards right, so this is a right axis deviation. And one thing of note that we have to look whether P waves are present or not. So just focus on lead V1 and just focus on the upward deflection after the QRS complex, and followed by that deflection there is a downward deflection. So the first upward deflection is most probably the P wave, and the downward deflection followed by the P wave is most probably the T wave. And similarly, if we look at these waves, just focus on AVF and look at the downward bump, most probably that's a P wave as well. So these are some features on 12-lead ECG that may differentiate AVRT from AVNRT. That first thing that in AVRT, and actually it's an orthodromic pathway, as we have discussed already, that in this case, in case of orthodromic pathway, the QRS is narrow, the QRS complexes are narrow, and mostly in case of orthodromic pathway, P wave is visible, although it can be invisible or it can be buried inside the QRS complex or even the T wave. But in the most of the cases of AVRT with orthodromic pathway, P wave is visible, and the RP segment duration is more than 100 milliseconds. What does that mean? The duration between the R wave peak and the P wave, that is called RP segment, and in case of an orthodromic Avrt, it's more than 100 milliseconds. So these are some clues that can point us towards the diagnosis of Avrt. The P wave we have seen in this ECG is an example of retrograde P wave. That means it comes after the QRS complex. On the other hand, if you look at this ECG, actually this is an ECG of an 11 years old boy presented with dizziness, and this is actually an example of Avrt with antidromic pathway, and the features favoring this pathway is wide QRS complex, and there is a inverted P wave between the QRS complexes, and usually in case of antidromic Avrt, the P wave is just before the QRS complex. However, there can be some changes or some differences between two ECGs of the same variety, but mostly I'm discussing what happens in most of the cases.